Hey guys, welcome back to my channel, The ENT Resident. Today we'll be continuing our series on septoplasty, and today is part 2 where we discuss about the procedure in itself, what are the surgical steps involved, and what is the post-operative care required in a case of septoplasty. You can also now purchase my notes. I have added links in the description. Okay, so let's get started with today's topic. So, before we go into the surgery itself and the different steps in it, first let's talk about what are some things we will be looking for when we do a preoperative assessment of our septoplasty patient. First of all, the internal nasal deformity, it needs to be properly assessed. What are the things we should be doing? We should be performing an anterior rhinoscopy. We should perform a nasal endoscopy. This will help us in detecting deformities, especially in the posterior part, which may not be as easily visible to you when you do anterior rhinoscopy. Then you should do palpation, and in certain cases, you may also need to determine the functional patency of the nasal airways using rhinomanometry, which is the objective measurement of functional patency of the nasal airways. And you should also assess any physical deformities of the medial and the lateral walls of the nasal cavities. So, all in all, we should first look inside the nose and see for any kind of deformities. Assess it properly before we decide to go ahead with septoplasty. Now, if there is any history of previous septal surgery done, whether it is an SMR or a septoplasty, first you need to determine the extent of the deficiency of the septal cartilage by palpating it with the help of a metallic probe. Then also look at the caudal margin of the septum. A lot of the times the deviation is just at the caudal septum, where so the person may end up having caudal septal deviation. So you should also examine that for any kind of dislocation. Then you should also check the valvular area. Sometimes over here, the Cottle's test may help you understand whether there is any problem involving the internal nasal valve area. Because if the Cottle's test improves the patency, then it will prove that the valve area might be involved over there. So that's another thing you should be checking. You should also check if there is any history of previous surgery. There may be any internal nasal synecdoche. So if any such thing is present or not. Then you should also check for the position and size of the anterior nasal spine and assess it by palpating just below the columella at the upper end or the philtrum, which is right over here, as you can see. So this is where the anterior nasal spine lies. You'll just palpate below the columella at the upper end of the philtrum here. And the other thing you should look at is the position of the anterior septal angle by pressing the tip of the nose gently towards the lip. Other than this, if the nasal mucosa needs to be decongested, you can also do that for proper inspection and palpation, because sometimes an allergic component may also be a part of this, and the swollen turbinates may not be allowing you to visualize the anatomy inside. So that's another thing you should look out for. And lastly, check the extent and size of any spur formation. So these are all things that you should remember when you are doing a preoperative assessment of a patient for septoplasty. Now, there are certain principles you need to remember for septoplasty. First is, preferably you will try to elevate the mucoperichondrial flap only on one side, mostly. But if it is necessary, you can definitely elevate on both sides. But doing it on one side prevents the chances of any kind of damage or tear to the flap. And if you end up having a tear to the mucoperichondrial flap on both sides, exactly at the similar identical site, that may lead to septal perforation later. So you have to be very careful about that, and it is preferable that you elevate the flap only on one side. Second is, you have to separate the union between the cartilaginous and the bony septum. I'll discuss this in the steps below. Then you have to straighten the bony septum by either fracturing it or excising the deviated parts of the ethmoid or the vomer part of the nasal bone. Bone. And at the end, you have to make sure that you mobilize the septal cartilage so as to bring it in the midline, and that will restore the patency of the nasal airway. So the deviated septum, which has been now been corrected, it should come at least near midline or in the midline if possible. That will restore the patency of the nasal airway for the patient. And if you see any other external nasal deformity, which also could be contributing to the issue, in that case, simultaneously a rhinoplasty should also be performed. These are some basic principles that you should keep in mind for doing septoplasty before you do septoplasty. Now let's talk about what anesthesia is usually preferred. So, in cases of septoplasty, usually we prefer using local anesthesia. And in local anesthesia, what we prefer is the usage of 1% lignocaine with 1 in 1 lakh adrenaline. So, what is the purpose of using this adrenaline over here? And as well as the lignocaine. So first of all, let's talk about how are we going to do this. So infiltration is usually given under the flap. So the bevel of the needle should be facing towards the septal cartilage or the bone when you are trying to infiltrate it. Now during infiltration, how do we know that proper infiltration has been achieved? You will see that the septal flap will immediately blanch, and that will indicate that adequate infiltration has been reached. So, blanching is what you will look out for on either side to know that the local infiltration has been done adequately. And infiltration should also be done properly. If there is any ridge or spur, you should be able to put the infiltration above and over and under the ridges and the spurs. Now there is two reasons why this infiltration is very important. First of all, adrenaline that we are using over here. Adrenaline has a vasoconstrictor effect, as we all know. So this vasoconstrictor effect, what it does is it reduces the chances of bleeding while you're operating on the patient. So that is one big importance of using adrenaline. Second is when you're doing this local infiltration, if we look at the image over here, let's look at try to understand the planes. So first we have the mucosa, which is this red colored structure that we are seeing. Then the green one is the perichondrium or the periosteum. And the cartilage or bone is the blue colored thing. So the area where we are trying to infiltrate is this plane, this pink colored part over here, which is the plane between the perichondrium or the periosteum and the cartilage or bone. So this is the plane where we are trying to infiltrate. So when we are trying to infiltrate here, this local infiltration itself will have a hydraulic effect, as a result of which what will happen, this itself will assist in flap elevation. So when you infiltrate in this plane, there will be a space created because of the hydraulic effect of the infiltration over here, and it will become easier for you to elevate the flap afterwards in the further steps. So these are the two reasons local anesthesia is very important. One is using adrenaline will give you a vasoconstrictor effect, and second of all, it will have a hydraulic effect which will make your flap elevation very easy. And this is provided you have put your infiltration in the right plane, which is underneath the flap. So that's about the local anesthesia. Now, sometimes in certain cases, we also use general anesthesia. When do we do this? General anesthesia is preferable, especially in children and apprehensive adults, because they might not be very cooperative if you are doing it under local anesthesia. And if you are using general anesthesia, then hypotensive anesthesia is the preferred choice over here. So that's about anesthesia. Next, let's talk about the position. How are we going to position the patient? Now, patient is usually put in a supine position and with a 15-degree head end elevation. Now, why is this 15-degree head end elevation important? There are three reasons for this. First reason is because of the head end elevation, it will reduce the venous pressure in the head and neck. Because it is elevated, the venous pressure over here in the head and neck region will reduce, and that itself will decrease the chances of intraoperative bleeding. And thirdly, it will also improve your surgical field visibility. So that is the reason why we place the patient in a supine position, but we make sure that we raise the head end by about 15 degrees. So That's about the position that we put the patient in during septoplasty. Next, let's move on to discussing the procedure in itself. So we have put the patient in the right position, which is supine position with a 15-degree head and elevation. And then we have done appropriate anesthesia required, which is mostly we'll prefer local anesthesia. Now the next step over here is to give the incisions. Now I have made a separate video on all the different incisions that is used in septoplasty. You can check out for more details over here. But the most common incision that we follow in septoplasty is something which is known as the Freer's incision. Now, if we look at the first image over here, this is where the Freer's incision is placed, and the blue line over here indicates where the Killian's incision is placed, which is another common incision used. So, Freer's incision is also known as the hemitransfixian incision. Now, what is this incision exactly? This is given exactly at the caudal border of the septal cartilage, and only it is given on one side, usually on the concave side of the deviation. Now, what is the reason we are using Freer's incision and not a Killian's incision? Killian's incision is an incision that we are giving about 1 centimeter behind the caudal border of the septal cartilage. So, when you give a Killian's incision, because you are giving 1 centimeter behind the caudal border, caudal septal dislocations cannot be operated on by using the Killian's incision. So Freer's incision itself has multiple advantages. First advantage, let's talk about the first advantage. First advantage is that, first of all, the place that the incision, the site at which you have placed, that is a very avascular site, as a result of which bleeding will be less when you give an incision over there. Second is, the mucosal edges are very thick in this particular region, which is why it reduces the chances of the risk of forming a tear over here. Third, it gives easy access to the whole of the septum. Whole septum access is very easy when you use a Freer's incision. That is why that is also preferable. Fourth is, as I mentioned before, if there is any caudal septal deviation, that can be treated only by giving the Freer's incision. We cannot use Killian's incision in that case, because Killian's incision lies about 1 centimeter behind the caudal border. And lastly, if we have any plans for rhinoplasty, this Freer's incision or hemitransfixian incision, that can be easily converted into a transfixian incision for rhinoplasty. So these are the 5 advantages of using the Freer's incision, and this is what we usually most commonly use. So now we have given the incision. Then we will deepen the incision to include the perichondrium. And our next step over here would be to raise the mucoperichondrial flap or the subperichondrial flap. So what have we done here? If we look at the image over here, this is the concave side of the deviation. We have given incision in the caudal end of the septum, and now we are going to raise the mucoperichondrial flap on this side. This will be done using an elevator which is known as the Freer's elevator. Now, usually, this mucoperichondrial flap is only elevated on one side, which is on the concave side. We prefer not to elevate the opposite side mucoperichondrial flap, which is on this side. Why is that? The advantage of doing unilateral flap elevation is that, first of all, it will ensure the viability of the cartilage. It will increase the chances of viability of the cartilage. And secondly, it will reduce the chances of any septal perforation or septal abscess or septal hematoma that may happen during the flap elevation, where you may end up injuring the flap. So that is the reason we will prefer to raise mucoperichondrial flap only on one side. Now, as I mentioned before, the plane of the flap will be, if we look at it, this red structure is the mucosa. Underneath the mucosa lies the perichondrium or the periosteum, and underneath that lies the cartilage or the bone. So the flap will be elevated in between this mucoperichondrium and cartilage. This will be your plane of flap elevation. So now this flap elevation, what would be the extent of the flap elevation? Let's look over here. So this is what our raised flap will be looking like, right? Once you have, if you look at the image over here, this is the septal cartilage. These are the bones. This is the bone on the floor of the nasal cavity. And we have raised the flap on the concave side of the deviation, right? Then after this, we have to determine how much will we extend, how much will we elevate the flap. So this mucoperichondrium can be, first of all, readily elevated. Let's look at the image here. It can be readily elevated up to the dorsum. This is your dorsum. But it should not reach the attachment of the upper lateral cartilage with the septum. So that will be our extent on this side. And then elevation of the mucoperichondrium towards the floor should be carried towards the inferior border of the septal cartilage, which is usually the level of a septal spur. And if indeed you encounter a septal spur in this region, you have to be very careful over here, because any attempt around the spur can end up causing a tear in the flap. So you have to be very careful when you're elevating it over here. And the posterior extent of the flap elevation, that will go over the bony plate of the ethmoid. So this is our mucoperichondrial flap elevation. Now, in certain scenarios, you may end up facing an issue while you're raising the flap. It might be difficult. The regions where you usually end up facing a difficult flap elevation is usually the junction of the septal cartilage above, at the level of the anterior nasal spine right over here. It can be adherent over here. In these cases, you need to use a sharp dissecting scissors to cut through the fibers to help you in elevation, and also in the region of the premaxillary crest and the premaxillary crest and the vomer below. So you have to be very careful in these regions while you're elevating the flap. It may be more adherent than usual. So now we have done our mucoperichondrial flap elevation. Now the next step over here would be to elevate the mucoperiosteial flap on the floor. So let's look at the image over here. We have raised the flap on mucoperichondrium here. But here we can see there is some mucoperiosteum on the floor of the nasal cavity. So now the next step would be to raise these mucoperiosteal flaps on either side. First, what we will do is, let's look at the image over here. This is where the anterior nasal spine is. We will first expose the anterior nasal spine, and then we will incise the periosteum on both sides of the anterior nasal spines with the help of a number 15 blade. And then slowly we will elevate the mucoperiosteum on both sides, as you can see over here. Slowly we will elevate the mucoperiosteum on both sides, and we will go posteriorly. Let's look at the image here. We will go posteriorly over here. So first here is the anterior nasal spine, then we have the premaxillary crest and the maxillary crest, and we have the crest of the palatine bone. Here we will raise the mucoperiosteal flap along this floor from front to the back. Thus, what we have ended up creating now here is, we have the mucoperichondrial flap on the concave side, and then we have these mucoperiosteal flaps on the floor. Then our next step over here would be to join these. Let's look over here. This is what it will look like. We'll join these subperichondrial or mucoperichondrial and subperiosteal pockets over here. We'll join them together very slowly. We have to be very careful that we do not end up causing any injury or perforation of the flaps when we are doing this. And if we see any adherent fibrous tissue over here, we should be using a sharp dissecting scissors to do the job. So now we have joined both the subperichondrial and the subperiosteal pocket. Now at this point is when we are going to do a bony cartilaginous disjunction. We need to mobilize the septal cartilage and separate it from its attachments to the two bones over here, the vomer and the ethmoid bone. So how are we going to do this? So this is our septal cartilage over here, and this is the red marked portion is the bony cartilaginous junction. Here we are going to disarticulate the cartilaginous septum from the anterior edge of the vertical plate of the ethmoid, which is this region over here. And this will be done by applying very firm pressure on the posterior part of the septal cartilage over here with the help of a Freer's elevator. And then we will dislocate the inferior border of the septal cartilage over here from the groove in the crest of maxilla as well as the vomer. And now, so what we have at the end of this bony cartilaginous disjunction is that the septal cartilage will now be free posteriorly as well as inferiorly. So this is the next step. After we have mobilized the septal cartilage, now that the septal cartilage is free over here, our next step would be to raise the mucoperiosteal flaps on both the sides. How are we going to do that? Let's look at the image over here. We had already raised the mucoperichondrial flap on the concave side. Then we had raised the mucoperiosteal flaps on the two sides of the floor. And then we had joined the subperichondrial and as well as the subperiosteal pockets together. Next, we will raise, because we have now done a disjunction between the bone and the cartilage, we are able to access both sides from this one side. So we will raise the mucoperiosteal flap on both the sides now. That will be our next step. Next, after we have done that, our next step would be to correct the cartilaginous deviation that we have. Now, cartilaginous deviation can be corrected in multiple different ways. You have to first look at the septal cartilage and assess what kind of correction does it require. Sometimes you may need to do just scoring. What is scoring? Scoring is basically, if this is the septal cartilage, on the concave side, we give this partial thickness cuts, as you can see over here. And these partial thickness cut helps to straighten up the septal cartilage. So sometimes just doing scoring is enough to fix the septal cartilage deviation. Then we can even do cross hatching. Cross hatching is basically something like this. Then you can even shave the convex side of the cartilage and remove the excess part. Sometimes, let's look at this image over here. Sometimes this is a caudal septal deviation. All you need to do is excise a portion of this inferior part of the septal cartilage and place it back into the floor, into the groove. So these are different methods. There are different methods like scoring, cross-hatching, or shaving the convex side of the cartilage, or wedge excision. Multiple different methods are used to correct the cartilaginous part of the deviation. And you have to reduce and reposition the septal cartilage over the vomer and correct the deviated septum. Next, we'll look at the bony septum. Now, in bony septum, sometimes the deviated part can be removed by either fracturing it and setting it in the midline, or you may even need to perform some kind of excision. So depending on what is required, we'll do either one of the two. Now, bony portions, unlike the cartilage, they do not have a tendency to go back to its original position after they have been repositioned. So usually we have to remember, we know that the two major bones forming the nasal septum is the vertical plate of the ethmoid and the vomer. Now, because vertical plate of ethmoid is giving support to the bony pyramid, so we have to be careful that we do not excise it up, because it forms a major part of the support to the bony pyramid. So what we will do here is, it is more desirable to fracture the vertical plate of ethmoid and set it in midline rather than excising its deviated part. If you come up with any kind of bony spur along the floor, that can be chiseled out separately. And you have to remember that anterior nasal spine is a very, very important structure, and that is something that you need to preserve. So if you do need to do some chiseling out, you will place the gouge to remove the bony spur just posterior to the anterior nasal spine, and then remove the entire thickened bony spine. So the bony septum or any spur can be done. There are three ways of doing it. Either you fracture it and set it in the midline, or you perform an excision, or you do chiseling out with the help of a gouge. So this is how we correct the bony septum and spur. So now our cartilaginous septum has been fixed, and now bony septum, if any deviation is there, is also get fixed. Now we will reposition the septum to the midline. So we'll now, after we have repositioned the septum to the midline, we have to inspect the entire septum again. Is it coming to the midline easily, or at least near midline? And if you are seeing that it has not come to the near midline, there may be multiple different factors over here. The things that you can check at this point, if it has not come to the midline, is maybe the mobilized septal cartilage is still overlapping the bony portion. So maybe you need to further trim it more. Second, sometimes the inferior turbinate can be very large, and that might be preventing the mobilization of the septal cartilage. In that case, you have to outfracture the turbinate or resect it partially to create more space. Third, the upper lateral cartilage may be asymmetrical, which may be severed to release the septal cartilage. Fourth, one or two vertical strips or square pieces of cartilage may need to be removed in an angulated septum to break its spring action. And lastly, there may even be some external nasal deviation which also needs correction at the same time, which also might be contributing to the problem. So you just look out for what possible issue it is over here and make sure that you reposition the septum to the midline. Now, after the septum has now been put into the midline, now we will place the reposition both mucoperichondrial as well as mucoperiosteal flaps back properly. And the incision that we had first given, the Freer's incision, that incision needs to be closed using some kind of absorbable sutures. And at the end of this, we will perform nasal packing. Now we'll pack both of the nostrils, and this pack will be kept for about 48 hours. Some places prefer to keep it for 24 hours, but I would say 48 hours is a good time for this. And now let's try to understand what is the purpose of this packing. The packs that you are placing, they are actually acting as an internal splint to the septum, and they help in adapting the mucoperichondrium firmly to the cartilage. So it is kind of acting like an internal support to the newly corrected septum that you have just placed. So the different reasons, the advantages of doing a nasal packing is that, first of all, it will prevent the development of any hematoma, which is collection of blood under the flaps. Second, it will help you in maintaining the flap along with the septal cartilage in the midline position. And third, if you place the pack properly, it will prevent any adhesion, which is synechial development, from happening in case, like say, while you're performing septoplasty, maybe you have by mistake ended up injuring the mucosa on the lateral wall. So if you do not place a pack over here, the raw surfaces on the medial and the lateral wall of the nasal cavity, they'll join up together and they'll form a synechium, which will lead to nasal obstruction. So basically, the patient's problem will be back. They'll be complaining of nasal obstruction again. So placing the nasal pack will help in preventing any adhesion between the medial and lateral walls. Now, it is important to remember that the packing should not be done under any pressure, because this may cause ulceration of the mucosa, and which will further lead to more issues. So this is the importance of performing nasal packing. We can either use medicated ribbon gauze for these cases, or more commonly nowadays, the recent thing that is used is Merocell packs. So that's how we do the septoplasty procedure. That is all the steps over here. If we had to summarize very quickly, so we position the patient in a supine position with a 15-degree head and elevation. We gave local infiltration, then we gave incision, which is the Freer's incision, and we discussed the different advantages of the Freer's incision. Then we raised the mucoperichondrial flap on the concave side. And I have also told you about the different advantages of doing a unilateral flap elevation. After we elevated the mucoperichondrial flap, then we also elevated mucoperiosteal flap along the floor. Then we joined these subperichondrial and subperiosteal pockets over here, after which we performed the bony cartilaginous disjunction and mobilized the septal cartilage. Then we raised mucoperiosteal flaps on either sides of the septum, after which we corrected the cartilaginous part of the septum, any deviation in that region. Then we corrected the bony septum and removed any spur present. And then we repositioned the septum back to the midline. And lastly, we place the nasal packing to give more support and prevent any kind of complications like synecdoche or development of septal hematoma. So that's about the different steps of septoplasty. Lastly, in today's class, we'll discuss a little about the postoperative care for the patient. Here, we will remove the nasal pack usually after 48 hours, and we will clear up the nose completely. And the patient should be instructed not to blow the nose or sneeze hard. Avoid any kind of strenuous exercise as that may cause bleeding. Some medications are started like oral antibiotics, analgesics, antihistaminics, decongestant nasal drops, and saline nasal douching. And then we'll tell the patient to come back for a follow up at the end of 1 week. So that's all for today. This was all about septoplasty, the procedure, how are we going to assess it preoperatively, what are the steps of surgery, and what is the postoperative care. In my next class, I'll discuss about the different complications of septoplasty. See you in my next class. Thank you.